have three individuals here, and we're going to go in the order that's in your agenda. Our first speaker is Dr. Colleen Allen, and she is the president and chief executive officer of the Autism Alliance. And basically, she's got a background from the University of Michigan, speech-language pathology. She's got her PhD from Wayne State University. She's currently an adjunct faculty there. And she spent the last 14 years sort of teaching in the speech-language acquisition and development space. And I'll turn over to her to do our first piece, and then we'll go one by one after that. You can do wherever you're most comfortable.
Okay.
And you do need, can you turn on the other mic for her? Big green button to it.
Oh,
Okay, and the confidence interval.
perfect. Okay. Okay, can you hear me? Hi, everyone. So I think probably the best place to start, which is what I always like to do with an audience this size, is to first ask how many of you out there know a person with autism, whether a family member or a neighbor, a coworker. Okay, so if you look around, it's the majority. And I thought that in the little bit of time I have here, I would first just get you some background information as to where things are in the world of autism, and especially in Michigan. A little bit about what we're doing, and then I'd like to talk about 2 or 3 pretty specific initiatives where we've been puzzled by the technology side of a very difficult, complex disorder. And, for those of you who know a person with autism, you probably understand that this is not a single disorder condition. This is behavioral, communication, sensory. This population comes with a higher incidence of comorbid conditions, psychiatric and other medical. And typically in a lifetime, an individual is going to tap multiple systems. So, from our perspective, both on an advocacy side and a professional perspective, we've really been challenged with how best to do this in terms of getting information from families, communicating information across disciplines, across systems of care, which can include community mental health and our Michigan rehab system, so the vocational side, the health systems, the education system. And I think what you're going to find by the time the 3 of us have finished with our 15-minute opening is that the issues are going to create a theme. And we talked a little bit a couple weeks ago on the phone and realized how similar some of our challenges are. So I'm going to pop through a couple slides here. Our work, we're a statewide nonprofit organization. We started with passage of the autism insurance laws back in 2012 and have been very busy since. We were all excited that happened, but didn't realize that most of the challenges in terms of working with insurers, working with care providers, in some cases new providers to our state and for our insurers, were coming online. So we've done a lot of work, and we are not a parent organization. We are a professional organization with clinical education and employment specialists. And we're positioned as a liaison in our state between families, providers, insurers, state departments, and our lieutenant governor, of course, who has a child with autism. So lots of work in the way of insurance implementation, which is again how we really got started. We're fairly new, about 5 years into our work. But the other work that we do is community trainings, community safety awareness, police officers, families, parks and recreation workers, even bus drivers. Anybody really, if you think about it, in the community that's going to intersect with a person with autism can benefit from a little bit of knowledge, and we do quite a bit of those types of trainings. What's been our newest area is our Autism Navigator service. We've been doing this informally since inception, taking calls from parents, helping them navigate systems, get them information. but received some funding through the state for a 2-year period to help launch this in a more formal way, build the staff and capacity to provide services all across the state. And herein lies some of our challenges in terms of that much information coming from families. And we're talking about, an incidence rate that's 1 in 68 now. And so we have significant volume and in a position to collect a lot of data. And we're trying to make some decisions about what we do with that. I think I'm jumping ahead on my slides here a little bit. I'm not going to go into too much of this. I guess I should just highlight that anytime you're talking about a disorder without a cause, a known cause or cure, and I think Jennifer can attest to some of this, you are potentially tapping into difficult families, difficult providers, beliefs about cause and cure, and information that's needed around best approaches, best practices, and how to guide. So all of that makes sense in terms of autism. And then again, the navigation side of it. So here became the first issue. Really, on a statewide level, I sit on the Michigan Autism Council, which is a governor-appointed board, and one of the first things that we wanted to do was create a registry. Because if you can believe it or not, we have no idea how many individuals are affected by autism in our state. We do not have good data. Traditionally, we've relied on special education numbers, which are really flawed if you know anything about autism. And eligibility for special education does not equal medical diagnosing. And so, so the numbers can either be really, really large, because I personally have come across many, many children who had an educational eligibility for autism, but that did not meet criteria for a medical diagnosis. And that alone, those two systems of how you assess and diagnose and determine eligibility can be very different. So we don't have good numbers. 60,000 is the number of children. Again, in Michigan, we have an age 26 special education eligibility span, which is a little different from other states, but we're not even really focusing on, when we say 60,000 children, we're saying 60,000 under the age of 26 with a special education eligibility. So the registry, knowing the numbers, knowing where the service needs are, county by county, school district by school district, community mental health by community mental health, is really, really important. And we decided as a nonprofit that can at least start to do these things on a voluntary basis to create a registry. And we're doing that in conjunction with the launch of the Navigator program. So, what we're interested in here is it's voluntary, and we're finding out from what's happened in a lot of other states that that's typically the case. What I would have liked is to see a mandated registry where all of our pediatricians, all of our primary care doctors are submitting data regarding number of patients on their caseloads. Because autism has not been a reimbursable service, we can't just look to claim data. It's just not there. So creation of a registry, I would say, for our state is a pretty significant priority. We're starting it. We've got about 200 entered at this point, and we're really focusing on how to get the information out there so we can draw families to it. So a registry, I would say, is probably one of our first challenges in getting good numbers. It also makes a big difference for funding and grants and everything else. When you're trying to make the argument that there's thousands and thousands and thousands, it's good to have good data and reliable data. On the navigation side, so the way our Navigator program works is we have set this up so that it's accessible to different types of users. We have people power. Our state dollars are actually funding the specialists and the operators. And then we also have a web-based tool, which does some of the same, but isn't complete. So when I think about another technological challenge, this is one of them, which is how do you help a family uniquely navigate what they need when you're talking about a spectrum disorder where one person or one situation looks nothing like the next. So that piece of it has been a little difficult. We can gather data about age and gender and school district and type of insurance and begin to help on the people side. But what we would love to do is create that tool so those families that don't want to talk to somebody or are up at 3 and 4 in the morning want to get their information. And we've really just begun to build that out. But that's certainly something that we are hoping to create soon. And then I think probably the other real common theme here is just how do you coordinate all of that care? That's one of our biggest challenges. Through our program, we would have an initial contact with families. We would help connect them to a service or support. We're not a direct service provider. Get them information. 2 weeks out, we're following up with that family. Hey, was the information relevant? Did you get what you needed at the time? What are the challenges at this point? What are the challenges 3 months out and 6 months out? So we have a continuous almost case management model with families. What I would like to see in the future is that not only did we learn from the family, yes, the therapy's going well 3 months out, but from the service provider, through access to their collection of data. Child is making progress, family needs support, so there's an internal communication system with our staff, but also through our service provider partners. And that holds for education. There's an education team that works with these children too, and typically those are siloed. What's happening in education is rarely communicated because you know what that means. It means your school social worker or your child's MD or therapist then has to participate in the education meeting to get the information across. Or in the diagnostic feedback session, for example. To include an education representative. So there's a real need to create a system where we can communicate about what's happening in these different levels of care and across disciplines. And I would say for us, that's really, really our biggest challenge, especially the kind of work that we do.
If we can hold our questions to the end for the panel. Our next panelist is Jennifer Jurgens. She's executive director for the Susan G. Komen of Michigan. She's got a long career in marketing and communication, as well as some formal training in supply chain management. And as many of us talk about the information supply chain, we very much appreciate that. So Jennifer, you're next.
So what Tim didn't mention is that I talk a lot with my hands, so I'm going to apologize right now about this. I'm going to try the sit down and talk thing without taking out Colleen or Rick. I decided today to, instead of doing my normal PowerPoint, to do a little bit more of a personal perspective on healthcare. I have 2 different perspectives that I wanted to share from a breast cancer point of view. My own personal healthcare journey through breast cancer, and then the people that we serve as Susan G. Komen of Michigan. I've always known that I've been at an elevated risk for breast cancer my entire life. My mother was first diagnosed when she was 30 years old. There was a remission. It returned before her 5th anniversary, moved quickly into her liver and into her brain, and breast cancer killed her when she was 36 years old, and I was 12. I moved around a lot as a kid. No one anywhere knew this about me. The only database, the only information is what I had up here from being a 12-year-old. Living in Hawaii, living in California, every doctor had a different idea as to when I should start doing certain types of tests and things. So being a little bit assertive, being my own advocate, I started mammograms at the ripe old age of 32, I believe. So we found my breast cancer when I was 37 years old. And I know that I am an ER/PR positive DCIS, BRCA 1 and 2 negative, but I took it a step further. I've also had all 28 known cancer mutations tested. I am negative for all of those, but I'm positive for a mutation that no one understands. I have what they call a VUS, a variance of unknown significance. So that could mean that the mutation, I could maybe fly someday or something like that. But it is on the gene that is known to cause breast cancer and colon cancer. So this little VUS qualified me for yet another trial or program within the Mayo Clinic. But what is interesting to me from a personal perspective in healthcare is that I have a primary care physician. I had the clinic that did my mammograms. I had the hospital that treated me. I have the Mayo Clinic that's doing something else. And because of my position within Komen, I've had the honor of meeting Dr. Marie Claire King, who's most widely known for her work in the BRCA gene, who's very interested in the fact that I'm BRCA negative, have this strong family history, and yet am not genetically predisposed for cancer. What's very interesting about this story to me is that I am the database. It's all up here. I am the only person that knows all of that. And so every time I go into another type of exam or whatever, it's up to me to relay that back out to everyone. Now, I'm uniquely positioned to do that. I did do my undergrad in supply chain management and process improvement, and I've been doing systems integrations for years before getting breast cancer and changing my career path dramatically. But wouldn't it be great if I didn't have to be my own walking, talking database? So at Komen, it gets even more interesting when you look at the people that we serve. We serve the underserved. So I don't know how people know our model, but what we do every year is we look at the community. We're a statewide organization. We look at the communities that we serve. We identify, well, here's the Affordable Health Care Act. Here's what's happening with the Healthy Michigan Plan. Here's the effect that that's had on the breast and cervical cancer control program. So where are the new gaps in breast health? This year, women under 40 are a gap. They're not getting coverage. And we're also looking at women who make just enough to have private insurance, but then don't get biopsies and things done because of their large deductibles. We also look at rural areas and different ethnic groups that for one reason or another don't go in and get these tests. Not only is there no database for these people, we're talking about the underserved, the undocumented. It's not even the fact that there isn't a database. Sometimes there isn't even a language that we can use to get these people in. I work for Komen because I think that every woman in Michigan should have the same opportunity that I had, which is to find breast cancer early and beat it. But we have right now huge disparities in our state. When we look at a community, we identify those gaps, we publish our RFA, organizations then come to us and apply saying, we can fill that gap for you. So Komen itself doesn't provide many direct services. We do some education and some outreach and a lot of awareness. You've all heard of Race for the Cure. A lot of awareness, but the services are actually provided by local clinics and hospitals and other organizations. So we raise the money, they apply, we pay out until we run out, and then we do check-ins to see how they're doing with those grants. So what do we know? Typically, we know that somebody went in and got tested. Now, one grantee, City on a Hill in Holland is a great example, does clinical breast exams. If that comes back abnormal, the person is directed to another grantee, in this case, the Holland Hospital, who can now do a diagnostic mammogram. The problem there is there's no handoff. There's no knowing at the Komen level if the person actually went through the entire process from an abnormal test to a diagnostic test. And typically with cancer, we're talking about multiple diagnostic tests before they actually give you your final diagnosis. And then onward towards survivorship. And because of this and because of the communities that we are trying to serve, we know people aren't going through the whole process, but we have no way of reaching out to them and connecting it. What I would like to figure out, and as part of this group I've heard some amazing things today, how do I understand or move people through what I know to be available? We have some great resources so that we can actually move the needle on a healthier Michigan and see that somehow. So one of the things I was asked to do is to come up with my what ifs, Jen's dream list, shall we say, of if information technology was all as seamless as we wanted it to be. I mean, what if we could simply have a patient-centered database between our grantees where this handoff would be seamless and it would be very straightforward. We wouldn't lose women throughout the way. What if, and this is going to go back on my marketing experience, what if that database could also be augmented to contain seemingly insignificant data points about their lives, about their family history, about their diets, about their active lifestyle, exercise, hobbies, education, everything. Referring back to, I think it was Mark who talked about the quantum patient. Because as much as I love the idea of personalized medicine, I feel like we're over here today, which is mass medicine, one to all, and over here we're looking at one to one. And I believe that in this group, we have the power to sort of shift to a middle ground, which in marketing, I learned it through some work I did with the American Heart Association, specifically the Go Red for Women campaign. There's a well-known marketing PhD. His name is Dr. Howard Moskowitz. He's the man that's responsible when you go down the aisle in the grocery store for all the different types of spaghetti sauce. How many do we really need? Well, we need exactly that many. Because he's done research that says within any audience that you're looking to speak to, there really exists 4 to 6 primary, he calls them mind types. In marketing, refer to it as personas. But somewhere between mass marketing and one-on-one, there exists the ability for us to actually communicate more effectively with 90% of our population by coming up with 4 to 6 different messages or programs. And I feel that this group and what we're talking about today is a great step in that direction. So the example with the American Heart Association, we learned that in their audience there were a number of people who wanted to get educated. They wanted to hear about it. There was another group who really wanted to help others. There was another group that simply wanted to donate. And by changing our messaging, not what we were doing, but the way we were talking about it or the way we were delivering it, donations were increased by 40% during that pilot. So if I were to look at the breast health community and give you an assessment without doing all the statistical analysis and clustering and all that, I would say that we face a large group of people who believe that their faith and medical care don't go hand in hand. There's a large population that believes that God will take care of them and that they're not going to go into the doctor. There's also our group, if it's not broken, don't fix it, which we see a lot. I was at the Michigan Health Policy Forum last week, and the economist said something like, no bones showing, no blood flowing, we ain't going. You heard of that? There is a group that just needs to be educated. There's a group that doesn't think it's accessible. It's not available for me. I live in the middle of the Upper Peninsula, for example. If we could identify those groups, and then we could really look at that big data to say people who fit in the accessibility group, people who think they can't get to a mammogram, have these other demographic things in common. They live in these counties, they're this age group, they are this background or ethnicity. And then what we could do in the future is to target these people with different programs. Obviously, talking about a big hospital system isn't going to work there. Talking about a mobile mammography unit that's making the rounds there is going to work. And I think that if we use the data and the processing that's available to us, we can make a bigger impact on our way to personalized healthcare. That's one of my dreams, anyway. What if, regardless of how a person got into the health system, and based on their mind type or whatever, we've found that this is someone who isn't going to go in because it's not broken, I'm not going to fix it. What if they go in for a toothache, and because of what they look like, we say, you're also going to get a mammogram? Because we could figure out, with what we know, that that combination might actually be very effective. And we do have a few partners that are currently doing this. We have a number of women that will tell you, yes, Komen, I went in because my elbow hurt, and they diagnosed me with breast cancer and saved my life. When I look at Michigan, and I look at the numbers, so there will be over 13,000 diagnosed cases of breast cancer in Michigan this year alone, and over 700 people will be killed by it. That is attention-getting, interesting data, but what I think we can move forward is actionable data based on the processing that we have now and the way that we can connect seemingly disparate data points to draw better pictures of who we're trying to serve. There's a Health of Women study that's currently going on. It's through the Dr. Susan Love Foundation. It's the Million Woman Study. I'm in it. Anybody can be in it. It's women who've had breast cancer and women who haven't. What they do is they ask you, it's a good word, a bazillion questions about everything about your life, with that end outcome being had breast cancer or didn't. And what they are attempting to do is to identify not the factor, but the factors, the ones that seemingly don't make any sense together, that put you in the highest quadrant for developing breast cancer. So if they can do that, what if we could look at the inverse, which is the behaviors that put you in a position to be less likely to develop breast cancer? If we can't cure it, could we prevent it? When I look at one last what if, and then I'll stop, one of the things that we really struggle with is to get people to report back to us. Like I said, we don't provide direct services, and our grantees are doing a handoff all the time. What if the programs that we put out into the market actually reward the behavior? I think about things like mobile apps that give people rewards for self-reporting on themselves. I think of things like gamification, which is one of my favorite new words, the Candy Crush of healthcare, where people would be so interested in the game that they wouldn't necessarily recognize that they were providing us as a state with the information that we would need to create the right types of programs to serve more of these people. So I've been challenging the audience to come up with the next, as we used to call it, killer app that actually makes us healthier. Thank you.
Our third panelist is Richard Stefan Nowakowski. He's Executive Director for Partners for Health, and I think I'll let him tell you a tiny bit about Partners for Health. But he's got a distinguished background in really looking at this intersection of what we used to call managed care, which we are now calling healthcare reform in a lot of different ways. I would say he's been sort of in the trenches of how do we do this and what the formula needs to look like from a number of different fronts. Been sort of on the front line with a variety of volunteer organizations. He's got a pretty comprehensive bio, so if you can find all the bios in the write-up. I'll turn it over to him, and if you have more slides, if you want to stay there, you can, or if you want to move up here, it's up to you.
Thank you, Tim, and good afternoon, everybody. We'll run through the slides real quick and then talk a little bit about the space that we're getting into with Partners for Health and why I think it's particularly relevant and important right now. Partners for Health, relatively new organization. For those of you that are in nonprofits, you know that it's a big day when the IRS sends you your letter that you're an official nonprofit. We got that about 6 weeks ago. So it gives you an idea of how new we are. Partners for Health, 4 leading nonprofits in the Southeast Michigan area, Neighborhood Services Organization in Detroit, Southwest Solutions in Detroit, Common Ground in Oakland County, and Oakland Family Services out in Oakland County. All very highly regarded organizations that have been in the human service delivery space for a number of years, and primarily in behavioral care space. Why was Partners for Health organized? For the reason we're here talking about what we are with health integration, that the cost of health care is frankly eating all of our lunch. You know, I don't know how many of you look at some of the bigger national statistics, but when you look at the percent of either state budget or gross national product going into health care, it's a one-way line, and it's going up, and we can't afford the current model. Why this space now? Medical care, as we've heard from a couple other speakers, accounts for, depending on the researcher, 10 to 20% of what makes us healthy or sick. The other is lifestyle, environment, human choices, biology, the things that we do, which generally our healthcare areas don't touch. And then third reason, healthcare systems and payers are facing increasing pressure to cut costs. You look at the state of Michigan, we got a big debate going on now of how are we going to pay for roads? We've got a big element in the legislature that doesn't want to raise taxes. So do you take it out of healthcare? Do you take it out of prisons? Do you take it out of education? Nobody likes any of those choices. But if we could get healthcare more efficient, you could deliver the healthcare. But frankly, the economics of healthcare are forcing us all to change right now. Will the Partners for Health model work? It's based on the work of the Camden Coalition and Dr. David Brenner, also supported by Dr. Corey Waller at Spectrum Health in Grand Rapids. They've got 2 programs that a number of years ago started working within their health systems to say, where's your pain? Who are the most complicated patients? Who are the people that are getting admitted 3, 4, 8 times a year? Who are the patients that are in the ER 30 times a year, 40 times a year? And is it all healthcare related? And the answers are coming back, no, it's not. And that's how Camden Coalition got started, that's how Dr. Brenner got started, is working within those communities, those systems, to say, we've got a group of patients that are very challenging, the systems and the components as we have it are not working well today. What can we do different to address these patients' needs, which it turns out that this very small number of patients are also some of the larger cost drivers within the bigger healthcare arena. So the thought is that if we can focus on some of these more complicated patients, get dramatic improvements in quality and cost performance, learn from that, take those learnings, generate or move those into less complicated patients, but in general, improve the overall delivery system. The Partners for Health model is a combination of nurses and community health workers. In our model, we are starting out requiring our community health workers to be social work credentialed. There are other models, both in the state and around the country, where community health workers don't need to have that credential. In other programs, they are commonly associate degreed individuals that get training, and in some cases, they are actually peer counselors that don't even get that level of training. The keys with the community health workers is that they know the community. They are comfortable going into some of the worst spots in the community in terms of, you know, risk, crime, disease, those things. But that's a key to making the program work, is establishing that relationship with the patient, going into their home and actually delivering our assistance, our care coordination within the home. We use 3 evidence-based tools: motivational interviewing, trans-theoretical model behavior change, and trauma-informed care. Probably the most important of that is the motivational interviewing, and the idea there is working with the patient to say, patient, what do you want to work on? You know, for Myself, I know every time I see my primary care doc, he's like, Rick, you need to lose some weight. I know that, but just saying lose some weight doesn't get much done. And we know that in healthcare. As we work with the patient and say, okay, you should lose weight, great. Nothing happens. How can they lose weight? They could walk around the block one more time a day. They could cut down on eating at fast food. There's a whole range of things that as we make it more concrete working with them, you get better results. Our model includes a 360-degree health assessment with the patient's clinical team, so we work primarily with primary care providers and or health systems that will be referring patients to us. We've got a criteria set so that patients that come to us should have 2 or more chronic conditions, multiple inpatient admits, multiple ER admits within the past 6 months to a year. Clearly, they're very complicated patients that the health systems generally know. We're doing a pilot project with one of the big health systems in the Detroit area, and we talked to one of their primary care practices to introduce the model in the program. And as we kind of talked about the patient criteria, the most complicated patients, asking them to work with us to start sending us referrals. And I ask, okay, do patients come to mind? And invariably, out of doctors and their staff, you get a head nod because they know who their most challenging patients are. They know the people that are in their offices 2, 3, 4 times a week, if that, or more likely they're getting the reports from the ER. They know that what they're doing isn't working. They know they could use some help. So we do that reconcile, we collaborate with the patient's primary, we do a home visit, assessment of physical and social determinants. We've heard from other speakers the importance of social determinants. And I'd say that's critical. It's going to become increasingly more important in healthcare, just as we look to have healthcare integrated into the bigger into the bigger support systems. The example I would use there is patient goes in to see a physician, they've got an upper respiratory infection. Doctor says, okay, you got an upper respiratory infection, I want you to take an antibiotic. They prescribe the course of antibiotics. Patient walks out the door. Doctor didn't necessarily assess, can the patient afford the med? Can they get to the pharmacy? So that's one of the things we do. We look and look at that setting and say, can the patient afford that script? Can they get to the pharmacy? So if the patient gets a script working with us and a primary care, we're going to want to make sure they get it and they take it. The example I gave of upper respiratory, when that patient doesn't take that script, that URI gets worse, possibly turns into pneumonia, patients in the ER, they get admitted. Say that's a failure of our healthcare system, particularly when we know that it was diagnosed appropriately, it could have been treated, but there were non-medical factors that resulted in it not getting treated the way we wanted it to treat. So we developed comprehensive clinical plan, working with the primary. Actually, the primary and the medical side drives the clinical plan. We do a social assessment to see, does a patient need help with food, housing, transportation? Literacy is an issue in healthcare. I heard a statistic the other day that of the general public, 85% of us are healthcare illiterate. And my editorial comment, we like it that way. We don't want to have to learn all this stuff. We want to rely on our care providers to do that. Yet, huge gaps in healthcare literacy. And think about how we educate our patients. Same thing. You walk out the door from a hospital discharge, you walk out the door from a specialist or doctor visit. I would speculate 99 out of 100 of us, you get a piece of paper put in your hand with a block of text. The doctor or the nurse may talk about it a little bit. You get the opportunity to say, any questions? And invariably, we kind of like, no, I'm fine, because nobody wants to admit we don't understand this. Yet, think about all the other ways that we learn, all the other ways we get educated, and we're totally relying on one tool. Partners for Health, we recognize that if people don't understand their chronic diseases, our resources, our team, we have a wealth of little video clips. So if we go into somebody's home and they don't understand what diabetes means with text or narrative, we've got little video clips we can work with them to help them understand that. So different ways to teach patients, to be supportive of them, to really be a patient advocate supporting the primary care physician to improve the overall care. For those of you that have been in Michigan a number of years, you may recall an old advertisement that was on TV, and it was from BASF, chemical company located in actually National, but locally in Wyandotte area. And a number of years ago, they had a commercial, they said, "We don't make your tires, we make them better." So that's what I'm trying to explain Partners for Health to people, is that we don't deliver your health care, but we try and make it better by addressing the collaboration, by addressing information gaps, by educating, by really, our goal is an activated patient. And what that means is a patient that understands their disease process, that can work effectively with their primary care physician and their doctors, and that has an element of confidence that they can impact their disease and they can make progress. So high touch, frequent home visits, a lot of collaboration with community providers. I talked about our sponsors being in the human service field. We have a resource database of, right now, I want to say about 1,500 community resources that address food, transportation, housing, that address what's called a patient's echo map or support team. You know, if we send somebody home that needs dressing changes, but they live by themselves and they've got no way to do a dressing change on their back, but that dressing needs to change periodically, and we don't ask, you have somebody that can help you with that, the care doesn't happen the way we want, we get less quality result, and those are things that we will look at, is do you have support people that can work with you? If not, we'll work with that member, that patient, and help them think about who can they develop for that support team. So success in Partners for Health model, again, an activated patient, better results out of the overall healthcare system, primary care physicians that are a lot happier because their patients are doing what they ask them to do and they understand it, reduce use of ER for a lot of primary care that goes on there, and reduced readmissions. You know, the question of kind of why now, Medicaid rebid. We heard Director Lyon talk about the Medicaid rebid this morning, covering 1.7 beneficiaries, $8 billion. For those of you working with Medicaid health plans or that population, I would highly suggest go take a look at a couple sections of the bid. Appendix A on what the health plans are required to do, and Appendix B, the scoring that talks about how they need to respond to that. That bid requires the health plans to provide community health workers. It requires them to address social determinants. It requires them to get more patients into primary care medical homes. It requires them to do more collaboration. I can guarantee you that with $8 billion on the table, those health plans are paying attention to this, and it's that type of public policy focus that Director Lyon has that will help move us all ahead. You know, if those weren't requirements, would the health plans step up out of the goodness of their heart and do that? A certain amount of the things they would. Other things, no. It's the public policy that moves them there. And I guess with that, that's the Partners for Health model. Got a lot of opportunities, and turn it back to our moderator.
Thank you. Well, I will ask one of my first questions to the group, and then I'll open it up to everybody else. Lately at MiHIN and with a lot of our stakeholders, we're having a conversation around what we call coordinating the care coordinators, or who is coordinating the care coordinators. As we talk about social determinants of health, as we talk about patient activation, we're getting a lot of overlapping responsibilities of who is in charge of coordinating the patient and who's on first. And not just, the fact that the patients are either somewhere between annoyed or confused. But how do we kind of pass the baton so that everybody who kind of touches the patient, actually tells the next group in the chain, and, I guess my vision is, and they at least know who the other care coordinators are, and they say, hey, and they're going to call you tomorrow, and they're going to ask you these kinds of questions. I mean, that would be really integrated, and we don't see that happen a lot. Could you maybe articulate how active, one, confirm or deny whether you see that's an issue, and then two, maybe how does it fit for your organization, or where's the opportunity space look like for that, coordinating the care coordinators?
So I would call it navigating the navigators because I think at least in autism what we have found is that within a health system there's usually, or within an autism care center, I should say, within a larger system, you may have that psychologist or that social worker who is the care coordinator. In the educational setting, that may be the school social worker. It's probably a service coordinator or a case manager within community mental health. So I would say what would be really helpful for us, and I would think that for families and for those professionals in those different systems, even if you had one point of contact, it was one liaison with the community mental health agency, whether it's the case manager for the families within that agency, that I could go to when I need information about that particular family. One representative from an ISD, one representative from each of the large health systems where most of the children are getting their medical care. And that if even among those liaisons we had a place where we could communicate either through a shared data system, that would be helpful for us. There's, like I said, there's so much information, multiple disciplines, but if you keep funneling that up to a key person, it makes your point of contact 3 or 4 as opposed to hundreds. So that for me would be one way to solve the problem of care coordination, at least from sort of a global navigator perspective on a state level.
I guess I would just add that one of the things that we've really been working on has been shifting people's perception of how and what Komen does. I'm not here trying to get people to support a charity. I'm here trying to get people to support a cause. And so what we've done is we've started partnering with people that others would tell me are our competitors. So in West Michigan and across the state, Komen is on the front end of a breast cancer journey. We do diagnostics, awareness, education, screenings, we cover deductibles. When you get that diagnosis, you know who's great to work with is the American Cancer Society. They do transportation to chemo. They have the Hope Lodge. They have great personal care wigs and things like that. And when you're going through that journey, you know what else is great? Gilda's Club. Gilda's Club is awesome. And I think that when we look at the people that if we all became patient-centered, we could create more of these relationships where the collaboration would be more natural, and that this poor patient who's going through this rough time in her life wouldn't get this, we've helped you as far as we can, bye. There would be more of a handoff. And in addition to that, I'm seeing more of that within our grantees as well. One of our grants this year was very specific to a breast health clinic. Yes, we will give you this money to do these clinical breast exams as long as there is a handoff to the hospital for the diagnostics, and that you come to us together representing a full diagnosis and helping a person versus each just handling your own piece. So I believe that shift in perception of who's a competitor into more of how we can collaborate to serve the patient better.
I would suggest that a lot of that that focal point is you and I, individual responsibility for understanding our own health and being able to be conversant with it with our caregivers. That's a big stretch. I mean, that's a lot of information, but we could all start to learn a little bit more. I'd say the primary coordination point is that primary care medical home. That primary care physician should be working with all the specialists, should be assisting the patient in understanding the big picture, but that's also why I think we're seeing the evolution to primary care medical home. The idea that if you've got a primary care physician or practice 1 or 2 doctors and a nurse, do they have the resources needed to do all of that? And I think we're seeing in today's world, probably not. We heard a few of the speakers talk about what's happening with primary care. The practices are getting larger. They're getting purchased by the big health systems. For those of you in the Ann Arbor area, Integrated Health Associates, very large primary care system. They got the right idea 20 years ago and started moving to integrated care and practices. A few years ago, St. Joseph Mercy put a deal together with them. They are now part of Trinity St. Joseph Mercy Health System. But it's a much richer care experience because that primary care, even though you can only see it for 8 or 9 minutes, they've got the other support team members to help work with you. So I see that primary care medical home, but also again, each of us individually. I had a situation about a year ago. I was an inpatient at St. Joe's in Ann Arbor. First time I was inpatient since I had tonsils out as a kid. I had a severe leg infection, had to be treated for about a week inpatient with antibiotics. They're getting ready to discharge me. Discharge nurse comes in and I start getting the playbook. You're going back to your primary care physician on this date. And luckily I knew enough of what was going on. I said, nope, I'm not going back to my primary. I'm going back to my infectious disease specialist because he's the one treating this handoff. And I'm not going to see him on Tuesday because labs have to be drawn on Tuesday so I can see him on Wednesday and have the labs. Luckily, I was close enough to the health system, I knew that. If I wasn't a motivated patient, I would have got sent back to a primary care on the wrong day, and I'm sure it would have gotten fixed. But it's that level of involvement that I think we all have to move a little more towards to recognize that the health system isn't perfect. I don't think anybody would accuse it of being consumer-centric. And if we wanted to get more consumer-centric, then we better start helping it move in that direction.
Other folks want to ask some questions before I field a couple more? One way in the back. It's very bright up here. We know you're out there. We just can't see you.
Okay, I do have a question. I think it's pretty much geared towards the Autism Alliance program you have. You spoke, I think, on your employment advocacy, and I know that there are quite a few employment programs within our community. One in particular that is funded through Social Security called Ticket to Work program that is geared toward assisting individuals with disability either enter or return to the workforce. So my question to you is, does the employment advocacy leverage programs like this to assist your population with either obtaining or maintaining employment? And if so, what does the outcome look like?
Did you understand the question all right? You're just a little bit too far from the mic, so we're not hearing you 100% up here.
Okay, I'm sorry. Your program, Employment Advocacy, does it leverage programs within a community, employment programs within a community, like the Ticket to Work program through Social Security, with assisting your population with either obtaining or maintaining employment?
Well, I probably should clarify. So on the education side, our goal through our Navigator program is to educate families and individuals about their options for employment. So yeah, I mean, as a statewide organization and working with MRS, we want to make available to families the information they otherwise would not have about what those might be. So that program you're describing, I do not know it personally. I'm not the employment specialist on the team, but we would want to know about that to get families connected to it. I will just say though, on the employment side, it's really twofold. It's, you know, we've had programs in place for years and years about trying to help people with disabilities. The part that's been missing for a very long time is we have to help the companies understand how to do this. And there's great energy around this right now. The Lieutenant Governor is on a statewide tour with Justice Bernstein to recruit corporations. But I think if I could just sort of highlight one of the employment challenges in the world of disability, it's fitting the employee into the job description, but then it's also helping those coworkers guide that individual. And there's been less of that focus than I would have liked to seen for the past several years. We have job coaches, but job coaches don't know the job, and job coaches are supposed to be temporary. So the employment side of disability needs a lot of work. I think MRS is energized to change that. I don't know this program in particular you're describing, but that match is really important. A little bit outside of today's topic, I think, on healthcare, but certainly an important area of progress.
Additional questions for our panelists? Yes, ma'am. So we can get a mic over here. Should be right behind you, Mary.
Thank you. You're collecting information from people in the work that you do. You're collecting information on housing and all kinds of resources. And this is maybe kind of a flip side of a different take on Tim's question. How confident are you, or what methods do you have to make sure some of that information is being incorporated into the clinical record that becomes part of the ongoing care of the constituencies that you serve?
I can start with that. As Partners for Health does our processes, and as we've designed our forums and our data capture, a couple things. One, we've been very conscious of designing variables, not big blocks of text. So for example, does somebody need housing? Yes or no, but then that would open up a couple of follow-up menus that get you more detail so that it's just easier to work with that data down the road. We formally capture that information on social determinants, assessments, and then plans. We track that in our information systems, which at this point are still evolving. We expect we'll be working with Med Network One, who is all of our sponsors belong to. They provide some registry support, some med record support for us. But basically, it's then sitting down back with the primary care physician and sharing that social assessment and determination with them so they understand what we're working on together around the social support needs. In some cases, our community health worker and or nurse, our plan is we will go to primary care visits with the patient. You know, as we get a referral, our standard 12-week course of care, we would like to be with that patient in front of that primary care provider 3 times at least, because if there's an issue with the primary or with the patient, the member not understanding how to best work with the primary care provider, we want to teach them that. You know, the idea of prepare for your doctor's visit, walk in with 2 or 3 questions. Do you need refills? What do you want to know? You know, what were you working on from the last visit? What kind of progress? Teach those members that if you need a refill, doesn't do any good to call up and yell and scream at the staff, that there's a process to get refills from a primary care physician. And just a lot of education on how to be a better patient, if you will, with not necessarily that as a motivation, but helping the member and patient understand if you want better results out of the healthcare system and you want to feel like you're making more progress, there's ways to go about it that will help. There's ways to go about it that will hinder you. Yeah, just try and educate along those lines.
Additional questions? I would just, if you have a question, raise your hand, we'll get a mic to you. How many folks in the audience are familiar with the patient activation or the PAM instrument? Just out of curiosity. Just a couple. Interesting. Okay. Because I think that's an interesting choice for Yeah.
Yeah, I mean, as Partners for Health is doing our work and designing a lot of our systems, we've really focused, or I mean, taken to heart what we've heard from a lot of national major foundations, which is they really want to see a lot more improvement in results reporting. You know, particularly in the nonprofit world, we do a great job of talking about inputs and how many classes we delivered or how many units of service. And we've been moving for a number of years more towards that result. But that's what we need a lot more of in the healthcare arena, is what is the result we're getting out of that. And it's difficult to get at. Dr. Jeff Brenner in Camden, they've been doing their program, I think about 4 years now. Mm-hmm. He is just starting to talk about wanting to move into randomized controlled studies to prove out some of what he's doing, but then that's also a little more difficult because of the small numbers a lot of these programs are working with. You know, I think if Dr. Brenner is working with 1,000 patients now, that's a lot. So a couple of the challenges in that space.
Other questions? I didn't see the mics move. You guys know about that networking refreshment center thing, don't you, that's outside? Well, if you will help me thank our panelists.